check a few things. So I want to see how strong you are, and I want to make sure that you can feel sharp and light touch, and then we'll check your reflexes, okay? All right, so shrug your shoulders for me. Okay, good, very good. Push my hands away. Okay, so I'm doing C4, C5. Now bring your elbows in like you're gonna pull up barbells and push up. Okay, good. Now bring them out like this, push out. So this is triceps, the other's bicep. Okay, bring your hands down and then tuck them down like that. So hold them down. I'm gonna try to pull them up. Hold, hold, hold. Okay, and then up. Okay, very good. You don't have to use two hands. My hands are just weak. So, okay, and put your fingers together. So we're just doing a strength test here. So spread them apart. There you go. All right, and then out. Hold them out there. So these are interosseous C8, right? Okay. All right. So now we're going to do some sensation tests. So I'm going to just say, does this feel like light touch? And you tell me if that feels like light touch. Light touch. So C4, right? Light touch. Same on both sides. So you always want to ask is it's the same on both sides because sometimes it isn't. They don't think to tell you or whatever. Right here. Yeah. So what nerve level is this? Thumb? 6. Yeah. Yeah. Okay. And then 7. Light touch. Same on both sides. Light touch. Same on both sides. Okay. So now we're going to do. Let's see. Where did I put my little toothpick? Hammer. Yeah, I got the toothpicks right there. Hammer. Yeah, yeah. Thank you. All right. So then we'll do light touch. So I either use a toothpick or a paper clip. The paper clips are everywhere. You never have to go looking too far for a paper clip. But you want something that's sharp enough to really do the thing. A lot of times the hammers and even the tongs will come with some pointy thing. It's really not pointy enough to really do that kind of exam. So sharp or dull?
Sharp.
Sharp or dull?
Sharp.
A lot of times patients will say, I can feel that. Is that the right answer? No, it doesn't tell you if it's sharp or dull. That's you're really getting A beta with pressure if they can just feel it and it doesn't feel sharp. And then sometimes they have hyperalgesia, right? And you do that, and they're like, whoa, what are you doing to me? And so that's a sign of some pathology. So it's always good to remark about that in your notes, and it gives you some clues about what's going on with their nerve roots. So if I have somebody that doesn't have any arm pain, I may or may not make them take off their clothes. But if they really aren't sure and they do have arm pain, we have to get down to skin, especially to do the sharp sensation. So we won't make her do that thing. But, so you check every dermatome, right? C5, C6, sharp or dull, 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 sharp or dull. Okay. And if you get abnormal findings on C8, then go on up to T1. Just you're trying to get normal sandwiched around your abnormal findings. So, okay. All right, so we've got our strength, our sensory, and now we're going to do our reflexes. Is anybody practicing pain? No? Okay. So if you're like me, you hadn't done reflexes since nursing school, right? Right? So with the biceps, the best thing to do is to get your thumb right on the bicep tendon and have their palms up. And so a lot of times I'll ask patients to, I just model it for them. Like put your palms up on your thighs and they spread them out like this. But what you have to do is you have to get a nice bend in their elbow to get a good reflex. So we're just going to check. Her reflexes aren't wild, but they're present. Yeah, right? Okay, so do you see that? So that biceps are the easiest ones to get. Triceps are hard, and brachioradialis is a little bit hard sometimes. But with the brachioradialis, you're looking to have a small movement of flexion. I find that if I just start lightly tapping here, just watching them. Sometimes it's just such a subtle thing. I don't see it. Yeah. And because when you tap the extremity, it makes it move. And if you have a trace of a reflex, you may not be able to tell, is it the reflex or is it just because I hit it? So sometimes you can ask patients, did you feel that as a reflex? And sometimes they'll say, I don't know. And a lot of times they'll say, yeah, I felt that. And so you could call that a trace if you don't really see it. There, did you see that? Yeah, I know you saw it. Did you all see that? So it's a real subtle one. And then 2 ways you can do triceps is you can, depending on whether you're right or left-handed, since I'm right-handed, the left hand sits, or the left arm sits nicely here, but the other one's not as easy to do. So what's important here is, number 1, that the patient can't be holding their arm up for you. And number 2, you want to hit right above the olecranon process, because that tendon's not very long, so you don't have a very big window. And it's not actually that easy to get a tricep on everybody. And if they have much redundant tissue back here at all, you can take your fingers and just pull it up. But one of the things I try to do is just make sure I don't hit the olecranon process. It's not that much fun for the patient to have there. And she's got just a tiny one. Did you see that? Let's try that again. You see, it's really subtle. And do you have arm pain or neck pain? Yeah. Yeah, so I tend to want to, I never can really figure out which way I want to be on these, but so start at the olecranon process and just pull your tissue out of the way, and then just watch your forearm. I'm not watching. Did you get one? I'm hitting your little olecranon.
No, you're fine.
Okay, so the other way to do it, if their shoulders will go, is you can pull them up like this and then have it. But they have to be able to come out pretty far. So, did you see that? Yeah. So, guys who are doing a lot of work with their arms, they've kind of desensitized their tendons. And so sometimes that's just a normal finding. They just don't have good reflexes. But like I said, the triceps not that easy. So if you think that, say you got it on one side and you're pretty sure you did it really well on the other side and they don't have it, you just have to use your judgment as to whether you should say that reflex is absent or whether you were unable to elicit it. So a lot of times, sometimes I just say I couldn't elicit it. So that tells the next person reading that, or me when I'm reading it later on, that, it might have been me, it might have been the patient, but I can't be sure that they don't have a reflex. It's just
Have them clench the teeth.
the Gendrastic maneuver, yeah. It can, yeah. I tend not to do that very much, but yeah, you can just say a reinforced reflex. So you don't even have to spell Gendrastic. You can just say the reflexes were present with reinforcement. Or if you're doing your lower extremities, you can have them do this. Yeah, I could do that today. But anyway, so her patellas are easy. I find it easier to do. I can't do patellas from this side. Is to just put my fingers on either side of the bottom of the patella and hit right in between. And if you do that, you can usually get them on even people with total knee replacements, because they still have a patellar tendon, right? So I think it's pretty easy to get them that way. And then up in my way in northern New Hampshire, people don't want to take their boots off until July, and they only take them off for a day. But I find that I can't get a reflex through pants, but I can get a reflex through boots. Don't ask me why. But I think part of it, see, hers is kind of, I would call that a 1+. Okay, they're not really wild. That one's a little bit better. But anyway, if somebody comes in and they have, say they have arm pain or even neck pain, you really want to get a good sensory motor and reflex exam of them. It's not quite as important that you get Achilles reflexes on somebody that's got neck and arm pain, or the vice versa. I personally think it's really a good idea to always do at least some reflexes on the upper and lower extremities, because once in a while you find a cervical myelopathy that somebody didn't expect or whatever, and so I think that's really important. Another good idea to ask people who have neck pain is in their history, is ask them if they're tripping or falling, or if they have trouble getting up steps. So then myelopathy, what goes along with myelopathy is proximal weakness, so hip flexors, shoulder, girdle muscles. Yes, dropping things, yeah. And another reflex that you want to do for cervical patients is a Hoffman's. And so you see a lot of different ways to do Hoffman's on the on YouTube University. And so flicking like that, just doing that doesn't do any good. Doing that doesn't really do any good. What you are trying to do is you're trying to quickly distend this tendon. And so the only way to really do that is to immobilize this part and then flick that. And I see some people doing this, like that hurts me to watch, so I don't want to do it to my patients. But if your patient doesn't mind and that's really what you need to do, then that's your deal. But I think this is a much nicer way of doing it. And if it's a positive reflex, what you'll see is their fingers will go like this, and that's yeah. And sometimes it'll just be the index finger, sometimes it'll just be the thumb, sometimes it's a wild thing with clonus even. You can see clonus when they have a really big myelopathy. So, but I might not always do that for somebody that just has neck pain, but if they're the least bit hyperreflexic, then that's something you should do. And it doesn't mean that you are going to, automatically get an MRI of their neck, but especially if they have no symptoms. Or sometimes if they come in with lower extremity pain and you've done your reflexes and you see, oh, they're hyperreflexic in their arms, you do a Hoffman and it's positive, but they have no symptoms here. They're not tripping, they're not having any problems. You don't need to rush out and get an MRI. Several reasons for that, but if you document something that's on somebody's anatomical issue on somebody's neck or their low back when it wasn't really necessary, if they have and something shows up and they have a car wreck or a workman's comp injury the next day, you've documented something that wasn't a problem and that somebody else could blame their injury or any symptoms on. I mean, there's just no reason to just do this imaging without an evaluation, a history, a clinically derived reason. Don't let anybody tell you I have to have my MRI every year. Well, no, you have to have. Well, even if it's MRI, it's not radiation, but it's if it's not necessary, then. All right.